Welcome to AETCM, the emergency medicine channel. A 60-year-old female, known case of type 2 diabetes, presented to the ER with complaints of acute onset headache and vomiting since 1 hour duration. On our initial 10-second assessment, patient was conscious, oriented and obeying commands. Coming to primary survey, airway was patent, no pooling of secretions, no gurgling. Coming to respiration, respiratory rate of 22 beats per minute, 22 per minute, saturation 98% in room air. Coming to circulation, BP of 160/90 millimeters of mercury, pulse rate of 80 beats per minute, all peripheral pulses equally palpable. Coming to disability, GCS of E4, V5, M6, no anisocoria. At this point of time, we take the pain score which comes around 6/10, so we administered injection PCM 1 gram IV stat. Coming to reassessment of the primary survey, the pain score was still 6/6, so we have given injection tramadol 50 mg IV stat along with injection MSZ 4 mg IV stat. Coming to amble history, a 60-year-old female, known case of type 2 diabetes, presents to the ER with complaints of acute onset headache. She describes the headache as the worst headache of her life, and headache was mainly over the occipital region. It was associated with vomiting. Vomiting precedes the headache. There was associated blurring of vision and neck pain. Vomiting was 2 to 3 episodes and projectile in nature. No history of any fever, weakness, altered behavior, any angle of mouth deviation, no history of any seizures. No other associated symptoms, no aggravating or relieving factors. Past history, no history of similar episodes in the past. Family history, no history of any similar CVAs or events in the family. Medication history, the patient is a known case of type 2 diabetes on metformin 500 mg MIDI. Last meal was around 12 pm. Coming to systemic examination, CNS, patient conscious and oriented, GCS was E4, V5, M6, power 4/5 on the both left limb, upper limb and lower limb, and 5/5 on right upper limb and lower limb. Reflexes, left side it was mute, right side it was flexor plantar. No anisocoria was noted at this point of time. Other systemic examination was within normal limits. Then we again reassess the patient. At this point of time, we noticed a fall in GCS. The patient had a GCS of E3, V4 and M6. The patient was confused at this point of time. So still the pain score was also persisting. We advise the patient to shift for an emergency CT brain. And once after the CT brain was taken.
Okay. So here from a history perspective, like we have a 60-year-old lady who had presented with the worst headache in her life kind of pattern. One important thing we noted was that it was of a very abrupt, very acute kind of an onset. Within an hour, it had gone to the peak, and it was worsening in spite of whatever primary medications we had given. There was no obvious vocal neurological deficits when she came in, but in due course she had developed altered sensorium, and there was also a history of vomiting, right? One key history is that was this event preceded, like the previous 48 hours, with any small events of headache?
No sir, no similar episodes.
What is it called usually? Like you're getting more like a warning kind of headaches previously. It's called a sentinel headaches. Okay, that will be like episodic, lesser intensity kind of headache, which usually happens before certain diagnosis, which fits into the description you are saying now. Right. So that history you have to take. Any other? Suppose this woman was of like 30 years and all. Any other important history you will need to ask? Probably a lady in reproductive age group coming with
apoplexy.
People on oral contraceptive pills again have higher incidence of intracranial IC bleeds. Okay, so that will be one history you will need to look in females. Right. Other than that, you have covered almost all relevant factors in history. Okay, fine. Continue.
Then we taken a CT brain. CT brain showing a hyperdensity area of bleed on the right side near the AETCM territory. Query suspecting secondary to aneurysmal rupture.
Okay, so you have, at this point you have taken a plain CT. Okay, right. So you have a patient with headache. Before going into the CT, you have done a detailed examination also. Anything else probably we could have looked for in a patient with headache before going into the CT, or if the CT is not available in your facility, will there be any other clinical examination which might kind of help us? Probably you should have looked at the fundus also. Okay, that can give you clues. Okay, right. And BP, what do you say?
169.
160/90 in a patient with non-hypertensive or
Non-hypertensive.
skipped medications or anything, or
No, sir.
no? Okay, fine. Now you have taken the CT, brain plane, which is showing a bleed. Okay, carry on.
At this point of time, we have again reassessed the patient mainly for vitals and GCS. GCS was still E3, V4, M6, and BP was 170/90 millimeters of mercury. So, since this is a case of IC bleed, a SAH patient, our target is to maintain a BP between 110 millimeters of mercury and 160 millimeters of mercury. We have
We're talking about the systolic BP, yeah?
systolic BP. Then we have also assessed the GCS. We have taken an ECG and just we ruled out any first degree heart blocks because we were planning to administer.
Okay, I think we'll discuss here. So you're dealing with the blood pressure in a patient with what looks like an SAH now, right? So what are the problems you're going to face? What if the BP is high? What if the BP is low?
If the BP is high, it can be mainly secondary to raised ICT.
What I'm saying, how is it going to affect the SAH?
The cerebral perfusion pressure will be affected if there is a raise because
It is going to be the other way around. So if the BP is high, again your bleed is going to increase, because if the BP is low, what is the problem? That is where your cerebral perfusion pressure thing comes in, because cerebral perfusion pressure is equal to
MAP minus ICP.
ICP. Okay, so that naturally your ICP is going to go up. In the other end, if your numerator, that is your map is coming down, again your cerebral perfusion pressure is going to get affected. So that is why the rule is to maintain normotension. What was the person's baseline BP? If you have a definitive answer, was that is going to be your target in the immediate phase. Again, it depends upon what intervention you are going to do, what time from the onset. Those kind of things is going to determine your BP target. But during the acute phase, definitely you are justified to keep the patient in a normotensive state. What about the volume status?
Actually, we need to maintain patient in euvolemic status. Previously, there was recommendation for hypervolemia, but as per the latest guidelines, we need to maintain the patient in euvolemic status.
Okay, why? What was the problem with the dehydration in SH? Again, same principles. You are going to increase your vasospasm with dehydration. So that is why we want to maintain a good volume status. It's not that hypervolemia. Again, hypervolemia, again sodium can get all way around. So those are things which kind of now we don't go for this hypervolemic kind of thing. At the same time, we need to prevent hypovolemia also. Okay. So that is with the volume and BP. So BP, you were telling something. Yeah, continue.
At this point of time, we have taken ECG and ruled out first
So BP, you didn't intervene.
Yes, sir.
You told 170, right?
Yes, 170 range. So our target was patients not a known case of hypertension patient.
Not a known
Not
case.
a known case.
Oh, okay.
So we have given one injection Lebetrol 10 mg IV stat,
Okay.
and we reassessed the BP. BP came down to 140/80.
Okay. Any other choice? Like you feel intravenous? Do you suggest anything else other than Lebetrol?
NDG is not a good choice in this patient.
Both sodium nitroprusside and hydralazine can hamper your intracranial pressure. So this is one scenario where probably they may not come up as the first choice. So Lebetrol remains the first choice because of this advantage of giving a short bolus and reassess. Okay, fine. So heart rate was pre-Lebetrol. How was the heart rate?
Heart rate was 85.
Okay. Do you expect any heart rate changes in SAH?
Yes, sir. If there is a secondary, due to secondary brain injury, there is a raised ICT, it can lead to a hypertension, bradycardia and altered respiration.
Okay. So that is with our conventional thought of bradycardia. What else? Cushing's reflex?
Hypertension, bradycardia and altered respiration.
Okay. So that is one thing. Apart from that, there is something called as neurocardiogenic effects. Okay. That is where again you get ECG changes also. You can get STT changes, T-wave depression, Along with that, you can have echo findings of cardiomyopathy and things like that. So that can also be part of this primary intracranial pathologies. Okay. So here you gave labetalol, BP got controlled. After that?
After that, to decrease the raised ICT, we have made the patient head and elevation of 30 to 45 degree.
Okay.
And we have given antiemetics, and we have assessed the BP and GCS every half hourly.
Okay.
And we have also given osmotic, we started osmotic diuretics also, like 3% saline was started as per the protocol we have started.
Okay.
But there was no indication as such because no anisocoria, no features of raised ICT was there. But as a prophylactic measure, we have started.
Okay.
And
just a minute, can we go back to the CT report once more? Like
a CT report showing a hyperdense area of bleed near the AETCM territory, secondary to coronary aneurysmal rupture.
That's it. So there was no intraventricular extension?
No.
There was no midline shift?
No midline shift.
Or mass effect features were not there? Okay, fine. Continue.
Then we were planning to take a CT angiography for this patient to rule out, to look for the size of the aneurysm.
So at this point, any other drugs?
We can give nimodipine. We were suspecting.
Okay, we'll come back to nimodipine. Anything else? Anti-epileptics? Is it indicated?
But initially it was indicated, but according to latest guidelines for prevention of any late post-traumatic seizures is not ideally indicated.
Yeah. So, as you told, most of the society guidelines have taken off anti-epileptics, empirical anti-epileptics. But again, depending upon the site and in a patient whose sensorium is significantly going down in front of you. So, we have not planned for a definitive treatment yet. Okay. And we are seeing a progression of symptoms. That will be the subgroup of patients which probably will benefit from anti-epileptics because naturally you are seeing them going down. Okay. Probably you are justified in loading those patients with anti-epileptic at that point. Okay. As you correctly said, as empirical anti-epileptics for most of the intracranial pathologies is now off. Yeah. Okay. So that is there. Continue.
Then we, since we are suspecting a aneurysmal bleed, we have started the patient on one stat dose of nimodipine also.
So what does nimodipine do?
Nimodipine is since a calcium channel blocker, but it can cause a slight vasodilatation of the vessels.
Okay, so it is used for prevention of cerebral vasospasm. What's the dose of nimodipine?
60 mg Q6H is ideally Q6H.
6H, yeah. 4 times a day, yeah, fine, yeah. It's
4 times.
It's 4th hourly.
6 times.
6th hourly.
6th hourly 4 times a day.
Okay, fine. Probably we'll need to count to check. What I remember is 60 mg 4th hourly.
Dosing intervals can vary.
Usually it is 60 mg 4th hourly, and if in subgroup of patients, probably if you are not able to give because of the BP and things like that, you can give 30 mg 2nd hourly. That was the dose of nimodipine. Yeah, fine.
And then we recheck the vitals, everything, then we shift the patient for CT angiography.
So you gave nimodipine also at that point. Okay.
We have given nimodipine, we have started the patient on 3% saline also, since there was no mass effect or midline shift or any features of raised ICT. Since we have a protocol like that, we started the patient.
Yeah, but you are justified in keeping the sodium corrected. That's okay.
Then we take the CT angiography, which show a aneurysmal bleed in the AETCM territory. Size was more than 8 millimeter was there. So we, at the meantime, we have informed neurosurgery intervention also from the side also.
Okay.
Then once after the patient arrived, we checked the vitals. At that time point also there was a fall in GCS was also there. The GCS came down to E2, V2, M5. So. Sudden fall in GCS, which was, then we checked the GRBS immediately.
Okay. Now you have an interval CT angio, right?
Yes.
So with that CT angio, you would have got CT brain images also. Was there a progression of bleed by then?
So there was a progression of the bleeds.
Yeah. Okay. And by this time, any midline shift or anything else?
Midline shift and mass effect was also there.
Yeah. So that explains the whole thing. It's a rapidly expanding subarachnoid hemorrhage. Okay.
Then the GCS fall down to less than 8, sir. So we intubated the patient at this point of time.
Okay.
And intubation, we checked the BP. BP was around 190, 100 at this point of time. So our drug of agent was propofol at this point of time. And intubation, we checked the BP. BP was around 190, 100 at this point of time. So our drug of agent was propofol at this point of time. And intubation, we checked the BP. BP was around 190, 100 at this point of time. So our drug of agent was propofol at this point of time. So our drug of agent was propofol at this point of time. And intubation, we checked the BP. BP was around 190, 100 at this point of time. So our drug of agent was propofol at this point of time. And intubation, we checked the BP. BP was around 190, 100 at this point of time. So our drug of agent was propofol at this point of time. And intubation, we checked the BP. BP was around 190, 100 at this point of time. So our drug of agent was propofol at this point of time. And intubation, we checked the BP. BP was around 190, 100 at this point of time. So our drug of agent was propofol at this point of time. And intubation, we checked the BP. BP was around 190, 100 at this point of time. So our drug of agent was propofol at this point of time. And intubation, we checked the And we also started, by the meantime, laboratory infusion was also started to keep the BP in the lower side. Then the GCS, we started the patient on sedatives also. The patient was restless. So we started the patient on sedatives. Mid-dose morphine infusion was also started at this point of time.
Okay. So it's okay to start morphine, but what will be the challenge usually in
We
starting the
cannot assess the GCS, and there can be pupils cannot be assessed. But
that's okay.
Because we started because the patient is restless, and further it can worsen the raised IC.
The only thing is that where you have alternatives, go for that. Definitely Fenta will be a good alternative. In centers where it is available, you can always go with fentanyl infusions. Okay. Then so by now the patient is intubated. And what were the agents given other than propofol?
Propofol or rocuronium were the agents we were given, sir.
Okay.
Then we assessed the BP. Laboratory infusion was started. 12 ml per hour has been started, and the BP came down to 1 mg per minute. 12 ml per hour we started, and BP came down to 140/80. Sir.
So you told dose of
Laboratory infusion.
1 mg per hour. 1 mg per minute. Yeah. Okay. So what's the problem with laboratory infusion? How long can you give it?
300 mg in 24
So usually it has a ceiling dose of 300 mg. So if you are starting at 1 mg per minute, you will be hitting the ceiling dose in 6 hours. Okay. So usually we will get off with a smaller dose of laboratory infusion. 0.5 mg is reasonably okay for most of the time. Okay. Yeah.
By the meantime, we have put the rails tube, Foley's catheterization, everything were done, and we were slowly tapering the laboratory infusion and adding other antihypertensives also. And nimodipine was given 60 mg, Q6H was added. Our target was to keep the ventilator settings was to keep a PaCO2 between 25 to 35 millimeters of mercury, MAP of 80 to 90, sodium of around 140, and potassium of more than 4. Gradually we were able to bring down the BP, but no active interventions at present were taken from the neurosurgery side. We were going for a wait and watch policy.
Oh, I wonder why that was the plan. Anyways, so what is the usual line of approach for aneurysmal SAH from interventional
we
point
need
of view?
to do either clipping or coiling has to be done, sir.
Before this, like we have a CT angio, right? So the next logical step would have been a DSA.
Yes, DSA.
Okay, digital subtraction angiography, because DSA can act as a navigation tool for your coiling also. Okay, so in an ideal situation, a patient like this who probably we feel is salvageable, I think one of the assumptions could be it would have been already an kind of an advanced progressive kind of bleed where the futility probably is what would have prevented an interventional treatment plan. Okay, if at all we are going for an interventional treatment plan, then we will go for a DSA. Along with that, if coiling is possible, coiling will be the next kind of thing. Now, the current evidence, if you go by, what is better, coiling or clipping?
Sir, as per the ISA trials, Barrow Institute, both coiling and clipping has equal outcome.
Still
Coiling is better than.
So because coiling has been proven non-inferior, and most of the scenarios, because it depends upon the size and all, you can have preferences. But as a general rule, it is better to go with coiling than an open clipping. Okay, fine. Then
Then we shifted the patient to the intensive care neurosurgery ICU. Then coming to SAH as such, there can be aneurysmal and non-aneurysmal SH, traumatic and non-traumatic is there. The risk factors like smoking, hypertension, alcohol.
The traditional thing is, as you told, most of the time it is traumatic. Non-traumatic, other than aneurysm, anything else you can think of?
Yes, sir. There can be malformations, perimesencephalic hemorrhages, amyloid angiopathies, bleeding disorder, diathesis can cause, and coagulation disorders. Sickle cell anemia has been reported to cause SAH.
I think venous pathologies can cause. Okay, that can also, the presenting thing could be looking like an SAH. Fine.
Then coming to the symptom presentation, the most common symptom will be a headache, which classically described as a thunderclap headache, with an acute onset, with the peak time will be within 30 minutes of onset of headache. and there can be projectile vomiting can be there, associated blurring of vision, vomiting, photophobia can be there. Neck stiffness is usually seen within first 6 hours of onset of headache can be seen. Then there is called Terson syndrome, where there is SAH plus vitreous hemorrhage can be seen. Then coming to the aneurysmal sites, most commonly it can be a ruptured saccular aneurysm in 85%, where the ACOM territory is more. Second comes the MCA territory, then PCOM, and finally the internal carotid arteries. In saccular aneurysm and fusiform aneurysm are the most common aneurysms that can lead to SAH. Coming to the
So you told about saccular and fusiform. One more is there. That is dissecting aneurysm.
Then we come to the grading systems in SAH. In 1970s, we used the Hunt and Hess classification that was mostly based on the symptoms. Then to the 1980s, we come to the Fisher classification, where SAH was approached based on the CT scan reports. Then in 2000, we came to Ogilvy classification, where the classification was based on the CT reports, where we predict the outcome of the patient also. Then we come to the modified Fisher grading in 2001, where the intraventricular hydrocephalus was also included. At present, we will look at the World Federation of Neurosurgery classification, where GCS and focal neurological deficits are taken in as the parameters. Okay. Then we come to the Ottawa rule of SAH, where 6 parameters are there, in out of which if 2 are positive, there are an indication for CT scan. Okay. Age more than 40, any neck pain or neck stiffness, and thunderclap headache, and onset during exertion, and limited neck flexion on examinations. If any, and with history of any LOC, and any 2 of these are present, we will go ahead with the CT scan. Yeah. And coming to the diagnosis, non-contrast CT scan is sensitive in 99% of the cases with onset within 6 hours, and it is sensitive up to 5 days. CT angio we will done in case of aneurysm. There is involvement of circle of Willis more than or equal to 5 mm. DSA be the gold standard in any case, where you can see the 3D visualization, size, everything, and plan for surgery. Then come to the management.
We'll wait there. So you told about a plain CT and the timing of the plain CT, right? Any role for MRI? Suppose there is no CT and MRI is the option. Will it be of any help? Again, you will need to know where it can pick up and where it will not pick up. Okay, definitely if you go for a GRE sequence, you might pick up a blood. But in a hyperacute kind of situations, MRI can be normal. Okay, so again, where after like 4-5 days, your CT sensitivities, as you told, will start coming down. But that time, the MRI becomes more sensitive, because it's the hemocitrin which is usually getting picked up in an MRI. Okay. Likewise, MRI angio also can help in finding out the aneurysm and all. Suppose the center does not have CT or MRI, and the physician feels that the patient is very much likely to have SAH. Is there anything he can?
Lumbar puncture.
Okay. So what are the findings in lumbar puncture?
Xanthochromia can be present.
What is xanthochromia?
Due to the breakdown of the RBCs, you get depositing yellowish discoloration.
Okay. Remember that xanthochromia might take time. Usually, if I remember, it is more than 12 hours, 6 to 12 hours at least it will take for xanthochromia to set in. So again, in hyperacute situation, it may not be there. So it will be like blood. Presence of RBC in CSF might be the diagnostic thing in a peripheral center where you probably may not have a CT. Or one more indication for LP in SAH will be very strong suspicion, typical presentation, hyperacute phase, even if the CT is negative within 6 hours. There also again, as per guidelines, you are justified in doing an LP. But what is the problem with LP? How will you differentiate an SAH versus a traumatic LP? Because at the end of the day, both might have blood and both might have RBC also.
The counts more than 2.
Correct. So basically, the thing is the difference in RBC count from the first sample and the last sample. If it is SAH, you are going to constantly see the same thing. In a traumatic bleed, the intensity visually itself will start coming down. Lab-wise also, the count is going to be varying. There are few more things, but the basic thing is to look for serial change in color in traumatic compared to persistent blood in SAH. Okay. Other thing will be opening pressure. Definitely in SAH, 60% at least, we are going to expect a higher opening pressure, CSF pressures, while in the other thing we are not anticipating. Okay. So that is with CT, LP, other MRI and DSA. So that covers most of it. Other laboratory may not be much helpful. Okay, management you can proceed.
Coming to the management.
Imaging, one more thing is that if at all we are going for intervention, okay, whatever intervention it is, like you are going for a coiling, always follow it up with the CT, because to make sure that the thing is sealed off, or the bleed is still there, or there would be new things setting in also. Okay, new aneurysms, new bulges and things like that. So those also needs to be done. A follow-up CT immediately after the procedure is indicated. Fine. Yeah.
And coming to the management, we basically prevented the increase in raised intracranial tension. We keep the patient head and elevation of 30 to 45 degrees.
Okay, you told about intracranial tension, and we are all talking so far about the specific interventions for SAH. Is there any intervention to decrease ICP?
EVDs.
Yeah. Again, if you have raised ICP, you are waiting for the procedure, the GCS is dropping down, you have already that midline shift is setting in, intraventricular extensions, there definitely a bedside EVD is indicated at that point. Okay.
Then we will supply adequate oxygen. We have to maintain adequate perfusion. The systolic blood pressure should be more than 100 for age 50 to 70 years, and more than 110 for 15 to 49 and more than 70 years. We have to maintain a map of 110, around 110. Supplement adequate IV fluids. We have to avoid hyperglycemia because it can precipitate cerebral edema. Hyperventilation in moderate amounts. We have to maintain a PaCO2 of 25 to 35 millimeters of mercury.
That again is debunked now. You are justified in keeping like 35, around 35 is more than enough. Okay. Yeah.
Then osmotic diuretics like mannitol and 3% saline if there is any midline shift or mass effect. Appropriate sedatives, and we have to maintain normothermia, and we have to also give antiemetics. We have to give laxative, stress ulcer prophylaxis and DVT prophylaxis if indicated. The target is to maintain a PaCO2 of 25 to 35, MAP of 80 to 90, ICP of less than 20, cerebral perfusion pressure of more than 60, sodium of around 140 and potassium of around 4. Coming to the complications, the early complications we can anticipate are the rebleed, acute hydrocephalus and seizures. The late complications are vasospasm, infections, delirium, cerebral ischemia and sodium abnormalities and pituitary dysfunction. Coming to the acute complications, the rebleed, it is maximum on the first day, and it then increases 1 to 5% daily for 13 days. Coming to vasospasm, the basic pathology is like the blood and blood products will cause us release of cytokines, endothelins and platelet-derived growth factors that will stimulate the tyrosine kinase pathway and causes the contraction of cerebral arteries. So nimodipine is the drug of choice we need to administer in the case of aneurysmal SAH.
How long will you continue nimodipine? It's 14 to 21 days. Okay. And other than nimodipine, any other measures for decreasing vasospasm? How will you monitor vasospasm in the first place?
Transcranial Doppler.
So basically, you can do a bedside transcranial Dopplers. Okay, that will help you in identifying the vasospasm. Suppose the patient is already on nimodipine. Okay, is there any other measures in an interventional center you can try? You can always go for intra-arterial vasodilators. So we go into the vessel and give. And even there are some reports of intra-arterial balloon dilatation during the acute phase. Okay, so those will be the other things. Fine. That.
Other thing is, one other complication is neurogenic pulmonary edema, which occurs due to the acute neurological insult that increases the sympathetic nervous system activity, causing pulmonary venoconstriction, and the treatment is always supportive. Then also for cerebral ischemia, we can also administer nimodipine. So nimodipine basically corrects the vasospasm and cerebral ischemia.
Okay. Fine. That's it. I think you have covered reasonably well. Only other thing will be from an endovascular point of view, there will be a subgroup of cases who you will go for stenting also. Okay, so what is the difference here? You have an aneurysm. By coiling, your meaning is that you are going to go in and put some materials inside, okay, like a coils kind of thing, and it finally obliterates. Okay, the other thing will be to use a stent to bypass the aneurysmal area, the bleed area. So both are technically kind of the basic physics behind is different. Okay, so both interventions are there depending upon the case. After the initial management, I think you have covered well. Anything else? Yeah, one thing will be in late, that is post SAH patients in ICU. One usual complication which we feel will be fever. Okay, that is again part of SAH only. That will be again non-infective kind of fever where you will need to treat it with specific measures. Okay. Okay, right. Thank you.